In order to understand what we're going to discuss regarding the capillary bed, you kind of have to really, in your head, visualize how this is happening in the body. And so what you've got is multiple capillaries, and you can see those cylinders there that are like capillaries. You've got many, many tissue cells around those capillaries. So those capillaries are trying to push out enough tissue fluid to feed all of those cells. And then inside the capillary, they're not showing you the protein, but you can definitely tell that those are red blood cells because they're little biconcave discs. So even though I'm going to show you kind of like a 2D drawn image of, this is just, me and my artwork, of what this capillary bed, how it looks like and how it's going to work, you need to kind of conceptualize this 3D image in your brain when we're talking about it. So in general, when you have the capillary bed, you've got an arterial end, and then you've got a venule end. And so on the arterial end, that's where the blood is flowing in, and of course it's coming through the arterioles, so it's going to have some blood pressure behind it, so it's going to have some hydrostatic pressure. But what's basically happening is the pressure inside is going to be high enough from the blood pressure that you see the arrows going out are much bigger than the arrows coming back in. So it's not that never there's any fluid coming back in, it's just not very much. Most of the fluid is going out on this side, okay? And that's the fluid that's going to go out, and it's going to bathe those cells, and it's going to deliver oxygen and glucose, and eventually it's going to pick up CO2 and other waste products. And then when you move to closer to the venule side, you notice now the bigger arrows are the arrows bringing the fluid back in. Now there's still a little bit of fluid escaping, but not much. But most of what's coming back is, there's a large amount of fluid coming back in, and that's how we return that fluid back to the circulatory system so that, it can make another go-round. So we're going to talk about why those arrows are so big on the arterial end and so going out on the arterial end and so big coming back in on the venule end. We're going to talk about what happens to the fluid that doesn't get pulled back in. And we're also going to kind of run through some scenarios of different things that can impact how this works. Okay, this drawing is going to take some explaining, but this is my rendition, and remember that I am not an artist, of kind of the capillary bed. So what you're seeing here is obviously this is the capillary, and I've tried to make you realize that it's semi-permeable. That's what all these little gaps are. And then inside the capillary, we've got what looks like little pink, that's red blood cells, and then the purple is protein or albumin. You could turn those P's into A's if it's easier for you to remember. But basically we've got our protein and our albumin. In between there would be the serum, okay? And then on the outside of the capillary, you've got cells, all right? I'm not going to draw a bajillion of them, but I drew enough to hopefully remind you that there are cells out there. And what I'm focusing on here is the normal function of the capillary bed, because once we learn how it all works normally, then hopefully that when I start throwing some alterations at you, then that makes it a little easier to understand as we go through. So this is the arterial end, which is like the previous picture I showed you, coming off of the arteries in the arteriole. And then this is the venule end. So this is where we're bringing the fluid back in, and we're going into the venous system. So what we have to look at here in this situation, remember, we're moving fluid in between these cells. So this is the fluid that's going to go out in between the cells, bathe the cells, and then eventually some of that fluid, or nutrients will go in. So what we have is basically an equation that's going to help us understand how this works. Now please, please, please listen to me. I have made up these numbers. These are not real. These are just numbers I've thrown on here to help you understand, because I think sometimes seeing it in a quantifiable form makes it a little easier. But do not go, well, blood pressure is exactly 30 millimeters of mercury. No, Michelle made up a number, okay? And the numbers are not as important as how they get altered when things change. So remember the soaker hose, or the fact that we're talking about that bolus of blood coming out of the heart. Well, as it travels down the vascular system and it goes from the major arteries to the arterioles to the capillary, when it finally gets to the capillary, you know it doesn't have that full oomph that it had when it started. I mean, just like the soaker hose, it's been giving off a little blood in different places all the way through. By the time it gets to the capillary bed, I'm going to say that instead of 120 millimeters of mercury, which maybe is how it came out of the heart, it's down to about 30 by the time it gets into the capillary bed, okay? So we have a positive pressure of 30. Now, what's that mean? Well, positive pressure, remember, is a pushing pressure. So since you've got this bolus of fluid, and I tried to show that here in the center, because we're basically going to have this bolus of fluid come through. So when that bolus of fluid goes through this capillary, it's going to stretch open those membranes and it's going to allow more fluid to push out. That's where we get that positive pressure. But hydrostatic pressure is the pressure exerted on the capillary walls. So it's basically plus 30. Okay, so if you come over here to the venial end, well, veins don't pulsate. I hope we can all agree on that. So the venial end really doesn't have any hydrostatic pressure that's measurable. The only place you can really measure venous pressure is if you're in the central vein. Okay, so like if you're in the vena cava, there's probably enough, pressure in there for you to measure that. But even there, it's going to be lower pressures, okay? But in a tiny little capillary, at the tip of your finger, it's not going to be a measurable hydrostatic pressure on the venial side. So what's 30 on the arterial side is going to be 0 on the venial side. Now, let's talk about the colloids. Colloids are those large proteins that I mentioned before, the red blood cells and the protein, or albumin. Albumin is the way that we say protein, usually in the blood. So, what you're seeing here is, you can take the time to count them up if you want to, but we have the same number of red blood cells and protein on the arterial end as we do on the venial end. Now, I didn't label them all there, but you've got the same number both ends. And that's because they don't leave the capillary. They travel from one end of the capillary to the other, okay? So, oncotic pressure is the pressure exerted by those colloids. And since there's the same number of colloids on the arterial end as the venial end, that number does not change. But also, oncotic pressure is a negative pressure. It's a pulling. It pulls things toward it, okay? So, oncotic pressure, I've assigned a negative 10 in this scenario, but it's going to be the same on the arterial end as it is on the venial end. All right, so now let's do some math. So we have a positive 30 for the blood pressure, or hydrostatic pressure. We have a negative 10 for oncotic pressure. That gives us a net filtration pressure of plus 20. So if you look at my little blue arrows here, that's my little blue arrows having fluid escaping this capillary, basically at a plus 20 kind of pressure. Since the number is positive, it's filtration out of the capillary because it's pushing out, okay? Now, that fluid is out here. Remember, there's tons of cells that I didn't draw, but that fluid is out bathing all of the cells, and then eventually it needs to come back in, all right? So we had a plus 20 going out, but all we have to pull it back in on the other end is the oncotic pressure, okay? And that is negative 10. It's the same as on this side. So we're going to pull it back in at negative 10. Now, again, since this number is negative, it's filtration back into the capillary, or it's being pulled toward the colloid itself. Now, I know a lot of you are going to say, hold on a minute, you had a plus 20 going out and a negative 10 coming back in. You're leaving fluid out there. You're right, we are. But you have another entity out there that picks up tissue fluid and filters it, and it's a part of your immune system that helps to keep our blood clean, and that is called lymph. So usually what's going to happen is that excess fluid that we left out in the interstitial space under this scenario gets picked up by the lymph system. And by the time it goes, remember, lymphatics are blind end, vessels that will bring the fluid back in. It will run it through lymph nodes. It'll be filtered, and then it will be dumped back into the vasculature in the vena cava area. So bottom line, you've got positive pressure on the arterial end pushing the fluid out, and an adequate amount of negative pressure to pull it back in. And you can kind of count on the lymph to pick up, that extra negative 10, or that extra positive 10 of fluid that's out there, clean it and bring it back to the vasculature. So hopefully this normal function of the capillary bed makes sense to you. So if we understand the normal function, now we can start talking about when things aren't quite so normal. So in this scenario, we've got the same capillary bed. I didn't take the time to draw all those cells and all of that stuff, guys, but they're still out there. But what we have here is either we could have a protein deficit where maybe the patient's nutrition has been crap, and so they haven't been taking in enough nutrition or food so that their albumin level is low, or maybe they had surgery and they lost some blood, so they lost red blood cells, so they're a little on the anemic side. But you can tell, if you look at my arterial end of the capillary here, I have far fewer red blood cells and proteins than I did in the previous scenario. But one thing that you can notice is the same amount on this end travels through that bolus of fluid through the capillary until it gets to this end. So whatever we have on the arterial end, we have the same amount of colloids on the venial end, okay? So in this scenario, what we're doing is the only thing that we're changing, we're gonna only try to change one variable so we don't make this too confusing. But in this particular scenario, we've got a blood pressure that's still the same as before, 30 millimeters of mercury, okay? On the venial end, we still have a blood pressure that is, 0, because there's no hydrostatic pressure there. But what has changed is we've lessened our protein and or our red blood cells. So basically, when you're lessening a negative, the number actually becomes less negative, so it goes more towards the positive. So instead of having enough colloids to make a negative 10 colloidal osmotic pressure, this is only going to maybe make them negative 6. Okay, so it's not going to be as much of a pulling pressure as it was before. So the math then works out the following way. We still have a 30, but now we only have a negative 6 holding fluid in. So what you're seeing is more fluid goes out on the arterial end because of this deficit of protein or red blood cells, okay? But now on the venial end, since the colloids stay the same, okay, that means we still only have a negative 6 pulling it back in. So we have a scenario where the filtration pressure out of the capillary is higher than it was before, and the filtration pressure back into the capillary is less than it was before. Now, that's going to create a situation where you've got, if you just look 24 minus 6, you're leaving like a plus 18 of fluid out there, right? Well, we know that lymph will take care of maybe 10 of that, but what happens to that other 8? Well, I'll tell you what happens to that other 8. It gets left in the third space as pitting edema. So when you go to grab your patient's leg or whatever, and you leave your fingerprints on their leg, it's because of this pitting edema. Okay, let's look at another scenario. So we're back to the same capillary bed, but now you can see I have restored the normal amount of red blood cells and albumin, okay? The same amount that's on this end will be on this end, so it's the same amount. But in this scenario, our patient's problem, and remember, I'm only changing one variable at a time. You've got to figure that in future we'll be dealing with situations where there are multiple variables to consider. But in this situation, our patient is just markedly hypertensive. So this is somebody who's maybe got uncontrolled hypertension, okay? And so when the blood's coming out of the heart, it's not coming out of there at a 120. It might be coming out of there at more like a 200 or even higher. So by the time it gets to the arterial, instead of being 30 or maybe even less, it's still 50. So we've still got some pretty significant positive pressure, that hydrostatic pressure, as the blood comes into the arterial end of the capillary. Since I've restored our normal amount of colloids, I went back to our -10 scenario that we did first. And so as we recall, the blood pressure is still 0 on this end. So you can see what's going to happen here. With the blood pressure being so high, what's going to happen is our net filtration pressure out of the capillary is +40. So you can tell I made my arrows bigger, I made them fatter. I mean, that's a lot more fluid exiting that capillary bed on that side. Then on the venial end, well, our colloids are still the same. It's still going to do the same job, so it's still only pulling in a -10. So that leaves 30 out in the interstitial spaces. We know lymph can take care of 10, but holy Toledo, that's going to leave quite a bit of fluid out in the interstitial spaces. And that's why my answer to this is edema again. And hopefully, if you think back to cardiac, when Lisa was telling you about your patients who are markedly hypertensive, we always talk about the fact that they, a lot of times, or your CHF patients, a lot of times they have a lot of edema due to their high blood pressure. Maybe now that makes a little bit more sense and you understand why that's happening. Okay, in this final scenario that I'm trying to explain with this capillary bed, this is a situation where we have a patient who's got some pretty significant edema. So out here in the interstitial spaces between all of those cells, this person's got edema and they've got some serious pitting edema, okay? In this situation, what happens is we've given them now a blood transfusion. So what we're looking at in this picture is the effect of a blood transfusion on a patient with pitting edema. And how you can tell too it's a blood transfusion, you notice you've got your purple, your protein. There's not quite as many of those, but right after a blood transfusion we should have a lot more red blood cells, right? So I've tried to draw some extra red blood cells in there. And again, it's going to be the same amount on both sides. So also, in trying not to alter too many variables, we went back to a patient who had a normal blood pressure. So our blood pressure is going to be a +30, but our oncotic pressure is going to be a little higher now because we just added a bunch of red blood cells to the mix, okay? So I upped it to -15. So basically what happens is now we have less fluid going out on this end, which is a good thing because we're already edematous. We don't want a bunch of fluid going out of there right now. But what happens is that on the venial side, we've got a -15 coming back in. Now, if you think about the fact that you also have, fluid picked up by lymph, that's a lot of fluid coming back in. All right. Now, is that what we need? Yeah, we definitely need that. But the risk is if you dump too much fluid back into the vasculature too quickly, then your patient, the vasculature gets overwhelmed with that fluid. And then what will happen is your patient will shift some fluid into their lungs because they've got all this excess fluid. So if we're going to do this, the biggest thing we need to worry about is making sure you're checking your patient's lung sounds to see if suddenly they sound wet or crackly. But the other thing is make sure if we're giving a blood transfusion to a patient who's got edema, to not only be checking for that and checking their pulse ox, but also hopefully the doctor has ordered some kind of diuretic to be given along with that, because we're going to be pulling some serious fluid back in. If you think about it, if you go back to my reference earlier, when I have that positive pressure go out, the 15, okay, 10 of that should be picked up by lymph. That only leaves 5 out of there. But we're pulling still 15 back in. So not only are we pulling that 5 back in, we're pulling an additional 10 back in. So I'm just trying to get you to understand that we'd be pulling in a lot of extra fluid from that edema, and we don't want to overload the vasculature at the same time that we're doing that. So anytime your markedly edematous patient gets a blood transfusion, first things first, you better be listening to their lungs for any signs of crackles or the fact that they might not be, dealing with that fluid quickly enough. And then also be watching for and hoping for an order for a diuretic so that we can get rid of that excess fluid. Another way to show this, and by the way, this came out of your fundamentals book, this came out of your Taylor, is on the arterial end of the capillary. Okay, you've got your blood hydrostatic pressure minus your colloidal osmotic pressure. That equals your filtration pressure, and you can tell the arrows are going out, right? And you see that's interstitial fluid around there. It shows you that on the picture. Then if you go to the bottom, it shows you your blood hydrostatic pressure minus your colloidal osmotic pressure equals your filtration pressure, and this time it's back in. So that's another visual. Hopefully between some of these visuals in some way, shape, or form, we've got that down pat and you understand it. If not, let me know. We'll try to find another way to explain it. So if I was going to summarize this whole area, I would say that hydrostatic pressure or filtration pressure from inside the arteriole is higher than the oncotic and osmotic. And I know we didn't talk a lot about osmotic, but there are some electrolytes and non-electrolytes in that plasma also. But it's higher than the oncotic and osmotic pressure. So fluid moves out of the capillary into the interstitial space. After the fluid has bathed the cells with oxygen and delivered some glucose and any other nutrients that it needs, and picked up the CO2, nitrogenous waste, and any other waste products that are made, then you've got osmotic and oncotic, primarily oncotic, pressures pulling the fluid back into the vessel on the venial side of the capillary. The fluid is therefore subject to the action of 3 separate forces: hydrostatic pressure, which usually translates itself into blood pressure, oncotic pressure exerted by the colloids, so basically protein and red blood cells, and osmotic pressure, which is exerted by the smaller electrolytes and non-electrolytes like sodium, potassium, and all of those other things, glucose even, that are in the vasculature at that time. So the action and the movement of that fluid is based on those 3 separate forces. So the organs on this slide are the major organs in the body involved in homeostasis. And homeostasis, we're talking not only fluid and electrolyte balance, which I know that's what we're focusing on in this unit, but you also have to remember there's acid-base as well. And so when you look down there and you see the lungs on my slide, I mean, obviously that's going to focus a little bit more on acid-base balance. But your kidneys, those are kind of the top dog on fluid and electrolyte homeostasis. Heart and blood vessels, a lot of people don't think about those as being part of the homeostatic function, but you've got to have the heart and the blood vessels to deliver the fluid out to the areas, and those blood vessels are part of that capillary bed that has to, filter fluid out, filter it back in, so definitely involved. The other 3 organs that are on here are all endocrine glands, and I'm not going to try to put in a compact little, mini endocrine lesson here, but if you remember the parathyroids, we talked about those in renal. Parathyroids help to balance your calcium, and of course calcium and phosphorus are reciprocal to one another, so you've got to have a little mention of the parathyroid gland. And then the 2 that we talked about earlier in the lecture, the posterior pituitary, because it produces ADH, and the adrenal gland, because it produces aldosterone, are certainly also involved, especially in fluid and electrolyte homeostasis. So we always have to bring this back in some way to the nursing process. And when we have patients that have disturbances or imbalances in electrolyte levels or in hydration levels, Our nursing objective is to know the importance of and demonstrate the skills necessary to assess and evaluate your patient for any type of fluid and or electrolyte balance or imbalance. So if you find them in balance, yay, put a thumbs up and life's grand and we go on. But if they have some type of imbalance, well then now we've got to go to assessment and we have to monitor the patients for any signs and symptoms of that imbalance or balance if they have it, and then recognize any deviation. So you won't recognize it's an abnormal level unless you actually know those lab values. So let me just say without any doubt whatsoever, sodium levels, potassium levels, and calcium levels need to be just things that you know in your head. The other ones, not so much. I'm not going to make you memorize magnesium or phosphorus or anything like that, but sodium, potassium, calcium, those need to be something that you can just shoot right out of your brain whenever is necessary. So you've got to be able to recognize deviations from normal lab values, and that's part of our assessment. We're going to do a lot more in that assessment, and at the end of this unit, we'll be talking about a focused assessment based on fluid and electrolyte imbalances and also, any type of homeostatic imbalances. But right now, that's what we're going to talk about for assessment. Well, of course, once we assess, we've got to plan and, do all of those other wonderful things, but eventually we're going to get to a point where we have to do something, and that's where our interventions come into play. Sometimes our first intervention is to notify the physician after we've done our assessment, by the way. You don't notify the physician until you've done a full and complete assessment, but once you have, you notify the physician of not only the abnormal lab values, but any assessments that you had or saw that go along with that. Then, more than likely, you will receive some type of order from the physician. Then it's our job to implement those orders, obviously to make sure that they make sense for the situation at hand. And then once we implement the orders, we've got to continually assess, because here's the thing. If a patient was low on something and our order was to give them whatever they were low on, do you think we could do it too well and then actually turn them the other way and now they're, have too high of a level? I hope you're shaking your head yes, because of course. So anytime a patient has an imbalance and then we go to correct it, we always have to not only assess for the original imbalance, but we got to assess for the fact that we might have done too good of a job and they might actually be, now the other side. We might have pushed them over the other direction. Documentation, that goes without saying. You have to document your assessment, anything that you actually do to treat, any type of problem that the patient has. Then what's sometimes even more important is going back and charting an evaluation of how well did the patient meet our goal. If our goal for the patient was to get their potassium in balance, I should say, then when we, give them potassium or we do something to take away potassium, depending upon what their problem was, we've got to go back and evaluate how well it worked. Did they reach the goal of getting them in balance or not? Are they still out of balance? If they are, this requires a new assessment and maybe some new implementation or some type of new interventions.